conditions, either not enough blood cells, too many blood cells, or whatever it might be. These
get
are
out early
blood
today.
cancers.
Yeah.
That's
So
how
at
that gets
noon.
broken down.
Oh, at noon on the egg.
Know your normals for your labs, obviously. Sometimes I'll have students that'll write on the scratch paper, like the renal labs, the way they change, and they'll do some other things before they get their testing underway too far. Next week, you can do that if you want. The spleen plays an important role in your immune functions. For leukemias, so the ones on your page, in general, the problem is Luke always needs white blood cells. In this case, the immature white blood cells have taken over. That's what the word leukemia means. So you have white blood cells, but the immature ones have taken over. They're crowding all the rest of them out, and they're allowing the dysfunction to occur because of that reason. Overproduction of white blood cells occurs, but these white blood cells aren't mature. So yes, they have a lot of white blood cells, as the word describes, leukemia, but the ones that are crowding things out are not mature and able to do the job. So therefore, because you have a lot of white blood cells, even though part of them are immature, you're going to have a crazy high leukocyte count. And oftentimes that's how this leukemias get diagnosed. Because the immature ones are crowding everybody else out, you have decreased platelets, decreased red blood cells. Right? Because there's too many white blood cells, they're crowding everybody else out. That's the counts that you expect to find with leukemias. There are 4 different kinds, and we'll talk about those separately in a bit. So your cover sheet for leukemias, generally speaking, for all of the ones we'll talk about, is too many white blood cells, but part of them are immature. They crowd out the red blood cells and the platelets. There are different causes of these leukemias, as you can see on here. Sometimes it's exposure to chemicals, sometimes it's chemo, it's an infection. Lots of things can cause the patient to develop leukemia. There are differences. The presenting symptoms sometimes are similar. Myeloid begins or occurs within the bone marrow. As the word says, lymphoid occurs within the lymph system. They all store the issue of the white blood cells, so that's not the difference there. Like any other diseases and disorders, we can have acute onsets, we can have a chronic onset that's been evolving over time. Symptoms of leukemia go along with the fact that the platelets are decreased because they've gotten overcrowded. They got crowded out, so you got all the bleeding issues that go with that. You have a crazy high white cell count number. Therefore, the fevers, the congested lymph circulation. And again, because your platelets have been crowded out, you have all the issues with the bleeding that we already just talked about before the break. That goes with all the leukemias that we will talk about. There's different cartoons, there's different mnemonics, there's different things that people use, but if you just think through the issues with immature white cells that can't do phagocytosis and do the job they're supposed to do, not enough platelets, what goes on with that, not enough red blood cells, what goes on with that, you should be able to figure out the symptoms without too much difficulty. Again, sometimes people use the mnemonic ANT, anemia, because the red blood cells have been crowded out. Neutropenia, again, because you say, you just told me the white blood cell count is high, but the neutrophils are the mature ones. They can do the job of phagocytosis. So therefore, your neutrophil count is going to be low, right? Because your immature ones have pushed them aside and crowded them out as well. And low platelets for that same reason. Because of all of those issues, you have bleeding issues. Low platelets is what we just talked about. The first leukemia we'll talk about is acute myeloid. It's a dysfunction in the myeloid system in the bone marrow, as myeloid suggests. The immature cells just keep building up, building up, building up. If it's a risk factor statistic I need you to know, I'll tell you that. These are just information for you to kind of look through. Exposure to chemicals is probably the biggest risk factor that we see with AML. So exposure to chemicals has messed up the bone marrow and messed up the production of the white blood cell to be correct. Chemicals being radiation, chemotherapy, cleaning products, benzene being one of the biggest culprits. So sometimes you work with patients and they say, oh, I didn't hurt anything, I don't wear that mask, I don't do that. Well, over time it could potentially cause a long-term issue. Same symptoms as we talked about earlier. Probably hallmark lab finding for AML. Again, a really, really high number of immature white blood cells. When you analyze their bone marrow, over 20% of their whole white blood cell count are immature. That's what causes the problems. So our treatment plan is focused on getting rid of those immature cells, and usually that's done with some type of chemotherapy. Again, we're going to try to decrease the white blood cell count, but you can't just get rid of the immature ones, right? Sometimes you affect the mature ones. That therefore, the side effect, the complication goes the fact that we wiped out your immune response. Your white blood cell count is high. Over 20% of those are immature. So the rest of them are the mature ones. We do induction therapy to try to target those. We can wipe out your immatures and your matures. And that's the issue. Causing a patient to have an ANC count of 0. Yours is supposed to be 1,500. So what risk of infection do they have when they have 0 neutrophils? High risk, and so therefore we have that issue, that complication. And because the platelets have been crowded out, low platelet count, increased bleeding, and all the management of that. Because it's a myeloid issue, we may have to talk about stem cell transplantation, which is when, if you recall, that's wiping out the bone marrow, trying to get some clean, fresh cells in there, and try to have it start behaving and acting normally again. Of course, if your patient has poor functions of other body systems, other risk factors, we may just have to symptom manage through there. Because some of those would not definitely be candidates for wiping out your bone marrow. So it's sort of a complicated, and of course, when more complications occur, the whole problem with you having 0 neutrophils, you having limited platelets, the complication could be, of course, bleeding and infection that would be the cause of death for these patients. Questions about AML. Myeloid means bone marrow in nature. Chronic is the same thing, except this has been going on for a long time. And what happens when these abnormal cells build up over a period of time, because they're chronic, they like to party and hang out in the liver and the spleen. That's just the way they know that's the popular place to be. So we have issues when we have chronic cell production problems. We have issues in the liver and spleen being enlarged, being dysfunctional, because that's where those cells just go when they've been abnormal for a long period of time, just the way it works. And sometimes this leukemia is related to some chromosome issue that parks itself in the wrong spot, or a lack of a better way of explaining it. Here's the statistics on this one. Again, a high leukocyte count, too many immatures, crowding out everybody else. Same symptoms that goes with leukemias, except additional symptoms when it's chronic is that enlarged liver and spleen, because that's where they've accumulated. You don't have to know these phases, it's just how it works. This is one medication. I said I'm not going to go over a lot, but this is one medication I would make a little note in my note. because it's come to use and it's been pretty effective for people. It changes the way that cells grow and divide, in the hopes that it blocks those immature cells from continuing to appear and cause havoc. This is patient teaching. Probably should have been in red. No antacids, no grapefruit. There's the grapefruit concern. So Gleevec changes the messaging for the cell division and tries to get the immature white blood cells to quit producing and quit causing problems. Pardon me? Patient teaching. Side effect. And then there's the chronic phase where it keeps building up in the spleen. You don't need to know any of these, but the spleen continues to get enlarged because that's where the cells have accumulated. Ongoing problems with low red blood cells, low platelets. We have what we call induction therapy, where we hit it hard with strong medications in the hope to, all of these are leukemias. They don't go away. We try to get their cell counts where we need them to be. It'll be a chronic state for the rest of that patient's life to try to keep that managed, to keep them in remission. Once you have CML, it's not like you're going to have, it's going to go away, you're not going to have CML. You're going to have CML forever, but our job as caregivers is try to symptom manage and try to keep that cell count where we need it to be. But hopefully not any complications the patient can't survive. Those are the two myeloid leukemias. The origin is the bone marrow mess up. That's where the mess up is. Now we're going to switch to lymphoid, where the mess up is in the lymph system. Still a problem with too many immature white blood cells, crowding everybody else out. But now the origin by the name is in the lymph system. This one is a typical pediatric cancer, so we're not going to spend time on it today. We'll probably cover it next semester when we talk about pediatrics. Again, peak incidence is age 4. So then if you're going into pediatrics, you may encounter patients with ALL. Again, too many immature white blood cells, crowding everything else out. Same symptoms as other leukemias. The cells have bunched up in the liver and spleen. The CNS, in this case, is often the site for the cells that are abnormal, causing neurological issues, involving sometimes some meninges, and that's where the patient sometimes comes in with. Trying to figure out, is this meningitis, is this some kind of leukemia, and one complete blood count sometimes will tell us what that is, or what's going on with this patient. Again, our goal is to try to keep you in remission, try to hit with medications, try not to make it too stressful on your liver, on the rest of the organs for that patient. This is chronic. Again, the problem is in the lymph system. There's all kind of, when you start to study for your going to collect them out, there's all kind of little cartoonies that keep it all sort of in one spot. What's a little bit unique to this one is the bottom bullet point there. People who have been in the Vietnam War were exposed, some of them were exposed to Agent Orange, which is the stuff coming out of that airplane, and they have found that to be one common factor with CLL. If they were exposed to that while they were in the Vietnam War. You know, we just don't know any better, and you guys have stuff in your nursing future that you're like, oh yeah, we shouldn't have been doing it that way in 2025, and here we are. All learning, all research, that's what trials are about. Again, high white blood cell counts. B symptoms, did you guys study those already? Another body system? I don't know why they're called B symptoms, but they are. So keep track of those 3 that go with that. Come up with some kind of terminology or something mnemonic for that. The B symptoms is a triad of fever, night sweats, and weight loss. Again, it's chronic. The abnormal cells like to accumulate and hang out in the spleen, in the liver, and since it's a lymph issue, you're going to have enlarged lymph nodes. And again, sometimes that's what the patients come in with. Or they're being seen for something else, and then your caregiver's assessing the other body parts and noted enlarged lymph nodes, and then we find out that they've got some kind of leukemia. Treatment, sometimes wait and watch, treat it with chemo, treat the infections. Anytime you need an immune boost, we could attempt or evaluate or consider IVIG treatments. No live vaccines, we already covered that part. And that's CLL. Questions about the leukemias? That makes sense? You expect a really high white blood cell count. You expect a low neutrophil count, because that's the mature ones. You expect a low red blood cell count, a low platelet count. Questions on that before we switch gears? Okay, in this case, DIS means difficult or defective or problematic. The bone marrow produces infective blood cells. Here are some statistics that go with these. Because they're defective blood cells that the bone marrow is producing, decreased white count and platelets, not that surprising. Symptoms that go with that. And because the bone marrow itself is messed up, really stem cell transplantation is really our only cure. Because the bone marrow is not getting it right to begin with. Managing, trying to get their counts back up where we need it to be. The new guideline for transfusion, by the way, is that the new guideline is anything less than 7 for hemoglobin. It used to be quite a bit higher than that. They transfuse like if your hemoglobin was 8 or 8.5, and now studies show that it really should be less than 7 until we transfuse. So stay tuned. That may change in your lifetime. Again, we can try to boost the bone marrow growth factors. We can boost the white count, mature ones. Neutrogen, I wish all drugs were named like that. Manage the low platelet count by possibly giving them platelets. What goes with that is iron overload. We can do phlebotomies for that, as we talked about before the lunch break. Polycythemia, as the word says, this case is too many cells. So we talked about polycythemia before lunch. That was not a blood cancer, that was a condition of the blood. Now polycythemia vera is actually blood cancer. The ones we're talking about after lunch all fall into that category of malignant cancers. Here again, there's too many cells and they become trapped in the spleen. That's the issue. You don't need to know this, but there are some risk factors that play into this one. Because there's too many cells, what way is the hemoglobin going to go? There's up. And what about hematocrit? Up. Again, a review. This first tube here, this is the way your cells are supposed to be equaled out in ratio. This many red cells, few white cells comparative to plasma. With anemia, you've got low red blood cell ratio. With polycythemias, you got too many red blood cells. And that's why everything else gets crowded out because of that disproportionate ratio. Because there's too many cells, that viscous, thick blood, increased blood volume, that appearance, those symptoms. The blood's too thick, and again, we can try to remove some of that blood to try to decrease the viscosity and thickness of the blood. Poly means many, too many cells going on. Chemo, other meds, symptom management. Thrombo means platelets. is in the bloodstream. Here, there's too many platelets running around with a platelet count that's higher than normal. There are risks that cause that. Overproduction of platelets is the problem here, and symptoms occur when platelets get to be more than 1 million. God bless you. All the symptoms that go with too many platelets, as we've been talking about. Too thick of blood causes sometimes tingling, numbness, those kinds of things, because it's not flowing sufficiently. He said, okay, this doesn't make sense. The platelets are dysfunctional, so therefore you may have bleeding going on, a little bit like the DIC conversation. So yes, they have too many platelets. The blood stream is thick, viscous, full, but because those are so crowded, it becomes dysfunctional, and the patient experiences bleeding, if that makes any sense.
So the blood just needs somewhere normal?
Yes, that's a good way to put that. So therefore, you have symptoms of bleeding that goes along with this. Again, we can try to decrease the platelet count, try to get your blood thinner, unless you've got bleeding going on. All things we talked about. Those meds to decrease your platelet count. Here, the problem is fibrosis, as it says, is there's excessive scar tissue in the bone marrow, oftentimes caused by gene mutations. Here's some statistics that have this one. In this case, there's scar tissue, abnormal production of blood cells. In this case, there's too many white cells, too many platelets, not enough red cells. Abnormal cells hang out in the spleen, causing an enlarged spleen. All the things that go with those cell counts being messed up. Again, we're going to try to get those cells back to some normal counts. And the bone marrow is fibrotic, it's scarred, and probably the only actual full treatment will be to do stem cell transplantation. Because the bone marrow itself is messed up. We may have to remove the spleen because its abnormal cells have accumulated and bunched up in that organ. Lymphoma, the umbrella term for that is anything that a cancer that affects the white blood cells. You will need to know the difference between Hodgkin's and non-Hodgkin's. Again, in this case, the white blood cells grow out of control. They have accumulated, there's too many, they don't die off the way they're supposed to die off. They collect themselves in the lymph nodes, the bone marrows, other body parts. Hodgkin's is called Hodgkin's lymphoma as opposed to non-Hodgkin's because when we look at that cell tumor, there's a presence of this, what we call Reed-Sternberg cell. Don't ask me why it's called that, but that is present when we look at that blood specimen. So we think this patient has some kind of lymphoma, and we don't know if it's non-Hodgkin's or Hodgkin's. If we see that cell present, the diagnosis will be Hodgkin. Here's the differences between Hodgkin's and non-Hodgkin's. Hodgkin's is typically younger people, a fairly good rate of survival. As you can see, it's diagnosed with younger people. So you present with symptoms of lymphoma, and we're suspecting it's a lymphoma, but we're not sure which type it is. And if we see the presence of that tumor cell, that's how we make that diagnosis of Hodgkin. And we kind of know more what we're dealing with. Again, the hallmark diagnostic is that gigantic tumor cell. Because it's a lymphoma, it's affecting the lymph system, that's how the patient may present. painless, firm, and large lymph nodes. Sometimes this presents by compressing on the vital organs. That's the symptoms they may come in with. The goal is cure. The goal is to get your counts where we need them to be. Your goal is to maybe overhaul your bone marrow and keep your quality of life and keep you in remission. Again, there's cartoons, there's other ways that you can keep track of this information. Some of those things work better in the brain than other ones do. That was Hodgkin's. Younger people, presence of that tumor cell. Non-Hodgkin's, same problem. Lots of white blood cells that have overtaken the lymph system. It does not have the presence of that tumor cell. And worse prognosis. Worse prognosis. Harder to predict what's going to go on with this type of lymphoma. So I remember that because I just remember non-predictable. So Hodgkin's for younger people, presence of the Reed-Sternberg tumor cell, a little more predictable how it's going to travel and move and grow and do, therefore more treatable. Non-Hodgkin's, older group, which is a risk factor, does not have that tumor cell, non-predictable, that's the issue. Because it can't quite figure out always how to treat that one, so I'm not sure how it's going to go and progress and move. Within these lymphomas, there are different subtypes, and we're not going to go through that today. But somebody that my son-in-law worked with got diagnosed with non-Hodgkin's, and my brain went right to this slide here, and they said, but he's got a better version of it than other people do. Which there actually are, there are subtypes that.
I have a question. Are any of these hereditary?
I can't probably say none of them are, but that's not a common correlation. Because we're human beings, there's probably something out there that probably is. Again, older population for the non-Hodgkin, prognosis varies because we're not sure how that is going to progress. Too many white blood cells, again. That's what the word lymphoma means. Still presentation of enlarged lymph nodes, fatigue, impact on body systems. It goes through different stages, as a lot of these leukemias do. That isn't always a predictor of how well that patient's going to do or not do. So just because you got diagnosed at stage 3 non-Hodgkin's doesn't mean that you're going to have a short life expectancy. There's so many other factors that play into that. Remission, chemo, other oncological treatments. Keep our numbers going on them. Okay, multiple myeloma, the blood cancer here is in the plasma cells. You remember that one slide that had the different tubes? There's plasma, there's white blood cells, and red blood cells. The problem here is in the plasma part of that. What happens here is that there's abnormal antibodies that get produced, and they crowd everything else out. It typically starts in the bone. This diagnosis is often confirmed by biopsying the bone marrow. That's where the abnormal antibody is what's causing the problems. The mnemonic people use to know the symptoms for this one is crab. That's kind of like the combination that we see. Again, kidney problems, decreased erythropoietin, therefore will cause you to potentially have the anemia. So that one pretty much goes hand in hand.
So would it be a low phosphorus?
Yes. Question? Again, there's some abnormal antibody. It's a protein that gets produced, and that's what causes the problem within the bone marrow. Classic presenting symptoms is bone pain. The problem is in the plasma portion of the blood count. With the star, that's kind of the trifecta for this disease. Older, presenting with back pain, and an elevated protein count. Because the abnormal protein is what causes you to have myeloma, that's where you're going to have an elevated protein count. And that's where you're going to have protein in your urine. Too much protein in the bloodstream spills over and goes into the urine. You're not supposed to have protein in your urine. That's typically why we try to do the content that we do in the right order. So you had renal last week, and then it sort of builds on that this week. So that's the typical trifecta. And sometimes they'll come in for a well physical as an older patient, and they'll say, gosh, I kind of have arthritis in my back. It's kind of bothering me, making me a little bit crazy. Well, tell you what, I'm going to do a urinalysis, and I'm going to do a complete blood count just to see where things are at. And lo and behold, we see an elevated total protein count in their bloodstream, and we see protein in their urine. And then sometimes we start to suspect that maybe this is what's going on. Symptoms, again, the antibody can cause, the protein can cause problems with your kidneys. Therefore, we're crowding out, messing with your bone marrow as well. Erythropoietin production is bad, down. The protein's crowding everything else out, and all your counts are going down. Again, no cure. Treat symptomatically. There's lots of drugs.
Usually, do they find it later? Because it's older people with back pain?
Yes. And sometimes they don't realize they actually have it.
Well, I mean, yeah, I feel like a lot of people go around with back pain. So.
Correct. Correct, and that's the issue. Usually they find it later, you're exactly right. A lot of these, sometimes we find later, like even leukemias and that, it's like, I didn't realize I've been so tired for so long. And you're like, yeah. And then you just look back on your last 6 months or your last year, and you're like, gosh, ever since Christmas, I've
That's
been.
probably asked, so what are you doing next week?
What's that?
I probably asked, like everyone who's 65 and older, like how they're doing today, like 6 months ago.
What's that?
Like if you come in, you're supposed to ask them, how are you doing today?
Correct. Correct. Good question. Because even if you got cardiac failure, people don't realize you always have decreased cardiac output, right? Or you're an atrial fib, and you don't realize that for months you've not been feeling well, you get lightheaded when you stand up, on and on and on. You're like, I had no idea. And you look back and you think, yeah, ever since a certain time, I've been feeling bad. So yeah, that's great additional thought on that. They have high calcium levels. And so you're trying to figure out what symptoms go with that one. This is a mnemonic that sometimes people use. Back knee, I don't really know what that has to do with that. Is that a pencil? I don't even know. I don't know why that makes sense, but maybe it does in your brain. It doesn't to mine, but whatever works. Okay, questions about that one. The protein is what causes the problem there. It's an abnormal protein that doesn't belong. And that's why you're going to have high serum protein levels. With multiple myeloma, you're going to have protein in your urine. Because your high protein levels, your colander starts to let some of that spill through to the urine. So protein in the urine, an older patient, back pain, and elevated protein counts should start to make you maybe be suspect of multiple myeloma. Questions about what we went over after lunch? But my best advice is when you're given a patient's diagnosis next week, is it too many cells of some sort? So when you're studying, I would just always break that down. Okay, so it's too many white cells, too many immature cells, not enough cells, not enough red blood cells, and kind of get that good in your brain, and you'll have your symptoms figured out. What I know about low platelet counts is this. What I know about low red blood cell counts are these symptoms. So if you can just physiologically figure all that out and process that for just a tiny bit, you'll be fine with that. Don't just sit and memorize symptoms. If you have symptoms that go with the disease, why are they having those symptoms that they're having? And if I can't figure that out, I'm either going to look it up or I'm going to ask one of the instructors about, tell me why they're having this that goes with that. And we'll try to do our best to help you figure that part out. I've got some NCLEX questions. We'll go over those.
think it'll be on the screen.
Oh, yes. You recording that for,
Well, you don't FaceTime.
okay, go ahead. In response to your questions, Mrs. Dowling and I, for finals week, we typically schedule our office hours based on your needs or your requests. So if you have a study group that you want to meet with us to prepare for the final, shoot an email sooner rather than later. If you have somebody that you want us to meet, us to meet with you, we can, because we kind of base our hours as we can based on your needs. We don't have a final review, a formal final review today or any other time. There are some reasons we don't sit up and tell you the 100 questions that are going to be on your final. Customarily, students, I'm waiting for this to get started. Customarily, students do typically on the final about what they've been doing in the last couple tests, now that you're all in the group. So there's no new content, there's no new something they're like, oh my gosh, never heard of this all semester, now here it is. You know how to process the questions. So by now, typically, unless you have some big life event the week of finals, people pretty much go like this on their final the way they've been doing. So if that's any help or not, I'm not sure. If you do have something, you're not well for your final, something big happens at home that is monumental, please don't take your final and take a chance of blowing the course because you had something big that happened between then and the final. We can postpone finals. We can, just because it's the final day, it doesn't mean that you have to take your final on that day if something big happens. So just let us know, because we've had some cases where a student have something, big catastrophe that week, and we didn't know about it, and then they came in and tried to take their final on time, and then, so. Let us know. There will be delegation questions on there. Those should be pretty easy by now. Don't give me somebody, or delegation, no evaluation, no assessment, no teaching, all that kind of stuff, right? Delegate BCT, there'll be flow questions on there. Those should be easy as well. By flow to your unit, don't give me somebody specialized that needs some special treatments, procedures, teaching, because I probably can't do that really well for you. Like I said, 8 or so dosage calc questions, the same proportionate number of psychological applies that you've been getting. It's the same percentage of questions as you've been getting. 7 or 8 questions per week. Go through your life-threatening dysrhythmias, complications, crises, all of them. So each week, pick those out. I met with a student and they said, I just don't know where to start studying. If you have a study group, I'm kind of one like, okay, there's going to be 8 questions from week 1, 8 questions week 2. I'm just going to try to pick out top 15 points maybe from week 1. And I'm going to see what you come up with for the top 15, and we're going to compare our notes to see if there's, oh yeah, I forgot about that one, or what about that one, or that. If you do make an appointment to meet with a study group with either Mrs. Dowling or me, have a game plan before you come in and meet with us. What do we want to ask about? Because if you say, just tell me everything you know, 16 weeks, I'll be, oh, I don't know where to start. If we flag this, can you explain one more time this, or this part we can remember, or something. So that would be my advice. Otherwise, I'm not going to make very good use of your time if we meet with you and then everybody just sits there and says, just keep telling us all you need to know. So if you come in with a study group, mark on your notes what it is that you want clarification about, or what it is you want explained again, or you want to go over again, or whatever it might be. So we make best use of your time. Meeting with study group does not mean Friday night at Buffalo Wild Wings. It means here on campus. We can do some online, which we've done, if you can't come to campus, but it doesn't mean. I study group once that said, we're all getting together Friday night. If we give you good snacks and good drinks, can you just come to our house and be with our study group? I'm like, no, we can't do that. So, anyhow, if you want to do it that way with your study group, that is perfectly good. Okay, I'm going to go over some exercise questions from today's content. We'll cover that, and then we can kind of cruise through the afternoon a little bit faster than I thought we might, but we either A, get out early, or we can just do some reviews of whatever. Okay, here's some complex questions. It's working. Pokey today. Probably just the user error, because it's Thanksgiving.
I was rushing this morning, didn't have time to get in.
blood.